Hello viewers, this is Dr. Sai signing in today's Doctor's Voice. Viewers, today we have got two distinguished consultants with us. On my right side, I have Dr. Steve Young, who is a senior consultant of respiratory medicine and critical care medicine at Mount Elizabeth Hospital. Welcome to my show.
Here.
Dr. Steve has area of strong interest in respiratory critical care, interstitial lung disease, and end-stage lung diseases. He obtained his basic medical degree from Singapore. Later, he was trained in respiratory medicine and intensive care from both Singapore and USA. He also obtained his EDIC meanwhile. So we'll be get to know about some pulmonary issues from him. And we also have Dr. Richard Kwak, who is a senior consultant, medical oncologist working at Mount Elizabeth Hospital and Gleneagles Hospital, Singapore. Welcome, Dr. Richard.
Thank you very much.
Dr. Richard is a medical oncologist whose area of special interest are in the management of sarcoma, gastrointestinal stromal tumor, melanoma, and lymphoma, as well as common cancers. So he has a distinguished career as an ambassador of oncology, both at Singapore and abroad. Welcome. So I would like to start with Dr. Steve. So about the pulmonary issues and respiratory issues. Firstly, I would like to know a common term, that is pneumonia. What are the common features of pneumonia for the general population?
Right. So a pneumonia is an infection of the lower respiratory tract of the lungs, typically the lung tissues, as versus to what we call an upper respiratory tract infection, like patients having flu, sinusitis, or viral infections. So the pneumonia, there's a bacterial infection, sometimes viral, sometimes fungal, and patients present with like fever, typically coughing, sometimes breathing difficulty. Some patients present with chest pain when they breathe in and out. And that's for the younger patients. In the older patients, they don't present with typical features of pneumonia as in the young. So they present with things like urinary incontinence, they present with leg weakness, they present with delirium, delusion. So if they start seeing things, then that might point to an infection, and therefore sometimes it is due to a pneumonia.
Okay. So who are at risk of getting pneumonia?
So anybody's at risk of getting pneumonia, but of course as you get older, then your risk of getting pneumonia is higher. Hence we recommend vaccination for elderly against pneumococcus, therefore to improve their immunity against pneumonia. Again, if you have chronic illnesses, you have diabetes, you have like kidney failure, liver failure, or your immune suppressant medications like steroids, then you're at higher risk of developing pneumonias as well.
I see. So the persons with comorbidities are at risk of getting complications and pneumonia.
That's correct, yes.
So I would like to know your experience and observation about impact of air pollution on the lungs or on the respiratory system. As you know, this question is very pertinent for us.
Correct, yes. So air pollution unfortunately is a fact, and we know air pollution is getting worse around the world because of industrialization and more industries using, as well as cars, as well as industries producing a lot of pollutants. So the lung, a lot of damage comes from all the particulate matter comes from air pollution. So they produce sulfur dioxide, they produce carbon monoxide, carbon dioxide, and all these what we call these microparticles of carbon. When you breathe them into the lungs, they can cause irritation, some patients can cause coughing, phlegm. But we worry about the particles we call the PM 2.5. These are very, very fine particles that when they go into the lungs, they actually can cause damage to the lungs, and they can go into the blood vessels, and they can cause inflammation in the blood vessels. So these patients who are in a constant exposure to these high pollution areas, they can develop things like asthma, COPD. Some patients also have increased risk of developing strokes and heart disease because these inflammatory, because these inflammatory materials go into the blood vessels and cause inflammation.
What you were saying about the name of the particle?
The PM 2.5.
PM 2.5. Oh, I see. So you were saying about some chronic conditions like asthma and COPD. We often see many patients complaining of persistent short of breath. So what do you think, what might be the common causes behind that?
Right. So when we talk about breathlessness, it can be both from the lung, sometimes it comes from outside the lung. So common causes of breathlessness in patients, of course, who exert themselves and then they get breathless. The most common is actually they are not fit. They have not exercised, they've been eating a lot, Then they feel guilty, they want to start exercising.
Physical deconditioning.
Yes,
is the most common.
deconditioning, correct. But if you talk about organic problems or problems with the organs, typically in lungs, it can present with asthma, which is a common cause of breathlessness, COPD for people who smoke a lot. Some patients who also have lung diseases, chronic lung disease, they can also present with breathlessness on exertion. A lot of patients with post-COVID as well do present with breathing difficulties because of either damage from COVID to the lungs or because there's a lot of what we call post-COVID or long COVID symptoms. They can present with breathing difficulties as well.
I see. That is an area which is everyone interested to know about the post-COVID situation of the lung, and
Right.
you were saying that long hauler or post-COVID syndrome. So particularly on the lungs, how do you see the changes, and whether are they reversible?
Right. So when we see COVID affecting the lungs, we have those patients with very, very mild symptoms and there's no damage to the lungs whatsoever. These patients can develop breathing difficulty, partly because it's a post-viral syndrome. They feel breathless, or the COVID itself causes them to have some very non-specific type of breathlessness. So they feel breathless on exertion, they get rest, at rest they feel better. But over about 2 or 3 months, most patients will have some improvement. Then we had those that had pretty severe COVID, where they were given oxygen therapy, where the x-rays showed signs of damage or fibrosis or scarring by the COVID. These are the patients that have objective reason why they feel breathless, because their lungs are damaged. And they do get better, although we have seen some patients that despite after 1 year after after COVID, they still have very bad scarring. But in general, some patients who've had fibrosis after COVID, they have been started on anti-fibrotic therapy. A lot of it have actually improved, and therefore the lungs can get better post-COVID, but it's not a guarantee.
Okay, but there's options which you can offer to the patient, like anti-scarring medications.
Correct. Yes.
Yeah.
Sometimes
And
you
that
try.
may
yeah,
that
correct.
may help.
Yes, it can help. Yes.
Okay. So what I would like to know from your personal experience about the otherwise long COVID syndrome.
Right.
We see many patients having myriad of symptoms from head to toe. How do you often see, and how can you help those patients?
Right. So that's a tough question to answer because it's an area still under research. Estimates point to about 10 to 20% of patients after COVID having post-COVID syndrome. And how do we define post-COVID? At least within the first 4 weeks of acute COVID, we call it acute COVID. From 4 weeks to 12 weeks after COVID, we call it ongoing COVID symptoms. Then beyond 3 months, then we classify them as post-COVID syndrome, or what we call long COVID. And people who are affected can be young, can be old, but typically we've seen them in elderly patients. We've seen them in patients who were admitted to ICU for severe COVID infections, patients who had a lot of comorbidities, like they were smoking beforehand, they had diabetes, they had high blood pressure, and we also see it more commonly in the women for some reason. The women were affected worse with long COVID compared to the male counterparts.
I would like to know about, you were saying about COPD and chronic lung conditions. So I got to know you have an area of special interest on ILD.
Yes.
What sort of disease it is?
Right. So in ILD, or we call it an interstitial lung disease, it's actually a disease of the lung tissue itself. So when you talk about lung tissue, it's the part of the lung between where the alveoli, or where you absorb oxygen from the air, and your blood vessels which take up oxygen. That small little space there is called the interstitial space. So when you have an ILD, this space becomes affected by certain diseases, and they fall into different categories. They can be caused by an environment, like people who are exposed to heavy metals or certain toxins that can cause fibrosis there. Sometimes them can be caused by medications, like certain drugs, and a lot of them are idiopathic. That means they have no known cause, and which idiopathic pulmonary fibrosis, or IPF, is one of them. They can also be affected as part of a systemic problem, like patients who have SLE, rheumatoid arthritis. This area of the lung can be affected as well.
So
as part
joint
of a bigger
disease
disease
can also involve the lung.
Exactly, right.
So lastly, what is the role of rehabilitation in lung patients?
Right. So rehabilitation is a very important aspect of recovery from lung injury, be it pneumonia, be it COVID, or patients who had COPD or even lung fibrosis. Because if you look at the downward spiral of patients with lung disease, what happens is that when they exercise, they feel breathless. As a result of feeling breathless, they don't exercise. When they don't exercise, their muscles become weaker, they become deconditioned. So they want to exercise, they feel even more breathless. So to break this cycle or a downward spiral of lung disease, you actually start them on a rehab program, which involves exercising both the lower limbs by doing staircase climbs, weights, upper limb exercises, because you have to exercise to brush your teeth, to wash your hair, you need upper limb strength. And we do stamina training. That means they walk distances, they walk inclines gradually. So the idea is to improve your stamina, improve your muscle strength. You will not improve your lung function, but you're able to do more things without feeling breathless. And therefore you break this downward spiral of getting worse.
And improves the quality of life of
Definitely.
the patient. Many thanks. Dear viewers, we were discussing about lung issues. We got to know about common lung conditions like pneumonia, how we can prevent them, and some common, particularly which is important in this era, post-COVID issues as well. We'll be talking about oncology issues right after a short break. Stay with us. Hello viewers, welcome back to Doctor's Voice. Today we will be discussing about oncology with Dr. Richard Kwak, who is a senior consultant in the field of medical oncology. Dr. Richard, initially we got to know that your area of special interests, you deal all sort of cancer patients, but you are especially interested about some rare conditions, sarcoma, GIST. These terms are a bit mouthful for me and for audience. Can you please explain in an easier way?
I'll be happy to. So sarcomas is an uncommon cancer. It represents about 1% of all cancers that we encounter in our daily clinical practice. Broadly, they can be divided into bone cancers and soft tissue cancers, and some of them can be fast-growing and some of them can be slow-growing. What's different from the other types of cancers that we see routinely is that young people are overrepresented in sarcomas.
I see. So what about GIST?
Okay, GIST is a subset of sarcoma. It is one of the first few diseases that we found a mutation that is responsible for the cause of the cancer, and therefore found a drug that we can target it easily and effectively. So it is a disease that starts from the intestinal tract, predominantly in the stomach. And if you look under the microscope, it looks like spindle cells, not the routine, round, aggressive-looking cancers that we see in stomach cancers.
Okay. So how do they commonly present, particularly of GIST?
GIST usually can be asymptomatic. Quite a fraction of patients are never known to have GIST until something happens to them. At autopsy, we found that they have got GIST inside them. But the vast majority will present with some kind of abdominal symptom, either pain, bleeding in intestines, anemia, for which they go see a doctor. Now, GIST can also affect the small intestines as well as the rectum. In the rectum, then patients may present with urinary complaints, blood in a motion, diarrhea, and some of those symptoms related to the rectum.
I see. So how can you offer treatment to GIST? Is it like, many of the cancers are, when get advanced, treatment options become limited and they cut down the survival rate. What about GIST? Is it that aggressive like common tissue cancers?
So thankfully, GIST is less aggressive than normal routine cancers like stomach cancer, for example. There's good medicine for it, even in the advanced stage 4 disease, and the treatment involves a tablet, a pill. And now we've got first-line treatment, we call it imatinib. We've got second line, third line, and now we have the fourth-line treatment. But it all harks back, if the disease is found early, we should always consider surgery in these patients. And if they're high-risk features, we should give them medication for 3 years to prevent the risk of relapse. And many patients are cured because of that. And for those patients with advanced disease, unfortunately, in those group of patients, they are still well treated, well controlled, and the median survival is still very long for the subset of disease.
I see. So about the diagnostic process, I think when a doctor or when a patient involves with a tumor in the stomach or in the intestine, it may be a bit difficult for the diagnostic procedures has to be up to the mark to diagnose GIST. Otherwise, it may be missed, if I'm not wrong.
Absolutely. So I think it all boils down back to getting the diagnosis right. We do scans to properly stage the disease. We take a piece of sample out to completely diagnose it. And in GIST, we also do one step further by looking at a molecular diagnosis. We want to see the mutation in c-KIT, which is the most common gene. Now, when we see such abnormal looking cells in the intestinal tract, we don't stop there. We must also think about other cancers in the belly as well in the appropriate scenario. In the appropriate age group, we consider other sarcomas as well, especially if they are within the abdomen or other parts of the body, in the limbs, for example. So getting the diagnosis is the key. And within the sarcoma family, including GIST, there's 70 different types, and therefore we need to get to the right type.
I see. So for tapping it right, advanced diagnostic procedures may play a good role. So what about melanoma? From which organ it originates?
Okay, so that's a very good question. So melanoma is a very aggressive form of skin cancer. Thankfully, it's not common in Asia, South Asia included. It's common in the West, people with fair skin, red-haired patient population. Now, in Asia, skin cancers are not common, but if it were to happen, usually in a sun-exposed area. Again, in Asia, we have some peculiar forms of melanoma where we have it on the hands and feet. So sometimes under the nails, sometimes on the palms, which are not typically sun-exposed and are not caused by sun damage. So these are the places. Again, the third group of melanoma areas predominantly in Asia will be mucosal melanoma. Inside the mouth, inside the oral cavity, the women have in a vaginal tract, men and women have in the rectal regions. So these are unusual. But what ties them together is that most melanomas are very dark in color. So if you have a dark patch of skin mole that's growing, that's bleeding, that's changed in character, then please get it checked out.
In those cases, melanoma has to be considered. So about lymphoma, what sort of cancer it is?
Lymphoma is a form of blood cancer. It's a cancer of the white blood cell, or some people call it cancer of the lymphatic organ. Essentially, patients present with a swelling of the lymph node, most typically lymph node in the neck, which they can easily feel, the groin or the armpit. Other organs that can be involved will be the spleen and the liver, but those are a bit later. Those are places where patients don't usually feel it themselves. Usually we do a scan and then we check it out. Lymphoma is also ubiquitous. It can happen in testes in men. It can happen in the brain as a primary brain lymphoma. So any place with a lymphoid organ can potentially develop a lymphoma from the area.
So what are the treatment options and outcome in a broader term?
Okay, so lymphoma is a disease which has got good outcomes, very treatable. We've got good drugs, and we always aim for cure. We're not aiming for life prolongation, survival benefit, but aiming for cure, and we tend to treat patients with chemotherapy upfront. Usually a period of 6 cycles to 8 cycles sometimes. Sometimes we may have to involve some radiation in particular cases, but essentially we're going for cure.
And with the intent to cure, that is very inspiring. So lastly, I would like to know about a common condition, lung cancer. You know, it is not uncommon this part of the world. Firstly, I would like to know from you, what are the common presentation of lung cancer in a nutshell?
Yeah, unfortunately, lung cancers are usually asymptomatic because when they grow in the lungs have no pain fibers. So you will not feel any pain until the tumor becomes relatively large. It involves the chest wall. That's where you develop pain or you develop fluid. You involve the air passages, you cough blood or you wheeze, or you develop a pneumonia because it blocks off one of the air passages and you develop a pneumonia behind the air passage. But for a majority of patients, lung cancers are asymptomatic until a late stage.
Until a late stage. Yeah. Many thanks. So about the lung cancer, what about the overall condition like diagnosis? What are the advanced methods and how do you approach for a lung nodule or tumor?
So someone like Steve will usually see the patient first. If the patient presents with advanced disease whereby there's disease spread, which is seen in the majority of cases, for example, fluid, we can remove some of the fluid for testing. We can take a biopsy of the lymph node or take a biopsy of an affected organ. If the disease is easily accessible in the lungs, a respiratory physician like Dr. Steve Young will put a scope in to the lungs and remove a piece of tumor tissue for testing. And then we want to get to the diagnosis and confirm the lung cancer. But we try not to stop there because lung cancer alone is just a descriptive term. We want to know the characteristics of the lung cancer, whether it's small cell or non-small cell. And within the non-small cell family, we want to know all the molecular characteristics so we can apply the right drug to the right patient.
Okay. So what about the treatment options, if you shed some light on?
Oh, the whole field of lung cancer treatment has evolved in the last 5 to 10 years. In the past, we only had chemotherapy and patients' outcome very poor. But now, with the whole barrage of targeted therapy, if you find a good target, you have a good chance at controlling the disease. The targeted therapy tends to be more suitable for patients who are non-smokers because they tend to be driven, their cancers tend to be driven by mutation. In addition to that, we also have immunotherapy these days, very suitable for lung cancer patients with advanced diseases, and we use it in combination with chemo or alone in the treatment of cancers.
I see. Role of surgery in such case in lung cancer patients?
Yes.
Yeah, so surgery is actually good for patients because surgery offers cure. So we aim for early stages of lung cancer and then we cure it. So from stage 1, stage 2 to even 3A, surgery can be considered for these patients. And after surgery, you add on either immunotherapy, targeted therapy, or patients, they need chemotherapy to enhance their survival. But of course, we are also seeing cases of patients with pre-cancers. That means when they do a scan, they find a very small nodule which cannot be characterized, and patients choose to go for surgery, and they find that these are actually pre-cancers, or we call them adenocarcinomas in situ, carcinoma in situ, or sometimes we call it AAH. And so these are pre-cancers.
Just about this condition, how do you practice about screening such lung nodule? Is it screenable?
Yeah, so with this lung cancer screening, we use the US task force data. They screen people above 55, people who are smokers between 30 pack years. It means you smoke a pack a day for 30 years or more, or you stop smoking but less than 10 years, then you qualify for lung cancer screening. But that's in the US. In the Asia population, there are no real guidelines to support lung cancer screening because we've seen cancers happen in non-smokers as well. And typically we've seen Asian women, non-smokers, have fairly aggressive cancers, and there are reasons which sometimes we do not understand why they develop them, especially there's no family history.
I see. Many thanks for shedding lights on the common issues, common cancer issues and pulmonary issues. It was a pleasure to have you on my show. I wish you have a safe journey back to your home.
Thank you. Much.
Viewers, that's all for today. Hope to see you on next episode. Till then, stay fine, stay tuned.